Hi friends, in this presentation we will discuss the significance of IOP measurement, different tonometry devices and practical aspects of applanation tonometry. IOP rise is the main risk factor for glaucoma. Most patients with raised IOP are asymptomatic. IOP is the only modifiable risk factor to prevent disease progression. Hence, tonometry forms an important part of complete eye examination. One needs to consistently get reliable and reproducible readings, keeping in mind that current methods we use estimate the IOP and may be influenced by ocular and non-ocular factors. Among the various types of tonometry devices available, only a few are used in routine clinical practice. Schwartz tonometer is influenced by corneal curvature, thickness and scleral rigidity. Goldmann applanation tonometer or GAT is not affected by scleral rigidity. It is more reliable and widely accepted for clinical use. NCT is easy to use and takes less time. However, compared to GAT, it may under or overestimate IOP at high and low ranges. Tonopen and rebound tonometer both correlate well with GAT in normal IOP ranges. Newer devices like ocular response analyzer and dynamic contour tonometer are influenced less by corneal thickness and are more accurate compared to other methods. Gold standard for clinical use is the slit lamp mounted GAT or the handheld Perkins tonometer. These measure the force needed to flatten a corneal area of 3.06 mm diameter. The prism on contact with fluorescein stained precorneal tear film forms two semicircular mires across the horizontal axis. These mires are visualized under the cobalt blue filter and the tension knob rotated to adjust the force needed to reach the endpoint of measurement. The prism is chemically disinfected in between patients, then rinsed in sterile water and wiped dry with a clean swab. This prevents damage to corneal epithelium. Calibration check is done regularly as an uncalibrated device can give erroneous reading even with right technique. After explaining the procedure to the patient, Paracan eye drop is instilled. The patient is seated comfortably with the forehead and chin in contact with the head and chin rest and outer canthi in line with the mark on the slit lamp frame. The zero mark on the prism must align with the white line on the prism holder. The dial on the tension knob is set at 1 gram mark. Fluorescein strip is applied to the conjunctival cul-de-sac and the patient asked to blink. The tonometer assembly is rotated in line with the oculars. With the slit lamp arm at an angle for optimal illumination with the cobalt blue light source at maximum brightness, the patient is asked to keep both eyes open and look straight ahead. The upper lid is lifted gently and the slit lamp moved forward to see the perilimbal blue hue. Then, looking through the left ocular, the joystick is gently moved ahead so that the prism head just touches the center of cornea and two semicircular mires are seen. The tension knob is rotated till the inner edges of mires touch each other. The reading on the dial multiplied by 10 is the estimated IOP. To avoid false eye reading, make sure the patient sits comfortably, loosens any tight-fitting collar or tie, breathes normally, fixates properly, does not squeeze the eyes and does not strain. One must not give inadvertent pressure on the eyeball while holding the upper lid. Also take care to not let the prism touch the lid margin or eyelashes, especially in eyes having narrow palpable fissure, are deep set or have dermatocalasis. Appropriate technique gives the correct endpoint where the inner edges of the mires touch each other. Inadequate fluorescein forms thin mires and underestimates IOP. Clean the prism, ask the patient to blink, reapply fluorescein if needed, and take the correct reading. Excess fluorescein forms thick mires and overestimates IOP. Clean the prism, ask the patient to blink, wipe the eye, and take correct reading. High or low prism position leads to unequal mires and false reading. Here again, clean the prism, ask the patient to look straight ahead, ensuring applanation at the center of cornea and take correct reading. To avoid false reading in eyes with astigmatism more than 3 diopters, before the measurement, rotate the prism about 43 degrees from the major axis to align with the red line on the prism holder, or take average of readings in vertical and horizontal orientation of prism. GAT tends to underestimate and overestimate IOP in eyes with thin and thick central corneal thickness. Although nomograms are there to adjust for this, none is validated. With corneal edema, GAT gives false low reading. In scarred or irregular cornea, it can give high or unreliable reading. Tonopen, if available, can be used in such cases. For EUA in children or for any sick patient unable to sit at the slit lamp, Perkins tonometer is used. For children and anxious patients not cooperative for GAT, NCT or rebound tonometer can be used. Contact tonometry is contraindicated in case of infective conjunctivitis, corneal infection, corneal epithelial defect, open globe injury, and suspected globe perforation for obvious reasons. To sum up, tonometry is an important part of complete eye examination. NCT may be used for screening, but not as a substitute for GAT. Perkins, tonopen, and rebound tonometry may be useful in certain situations. GAT is the gold standard and widely accepted method in routine clinical practice. It is possible to consistently achieve reliable and reproducible readings with the appropriate technique.